My name is Robert Hansen. I'm an esophageal survivor. I've been associated with ThyCa for over 15 years. And it's my pleasure today to introduce Dr. Jochen Lorch, who will discuss immunotherapy in follicular thyroid cancer. Dr. Lorch is a medical oncologist and director of the head and neck and thyroid program at Northwestern University. You will detect a slight accent in that his degree was from the University of Regensburg in Germany. He spent the dominant amount of his oncology career at Dana-Farber. He was there for 13 years. And in 2001 and 2021, he left for Northwestern University. He's a member of the NCCN Thyroid Cancer Board, and he's an active member of the ThyCa Medical Advisory Board. Dr. Lorch's first ThyCa meeting was in 2010, and I met him I heard his first lecture in Philadelphia at our meeting in 2013, where he gave a fascinating talk about a patient, New England patient with anaplastic thyroid with a very rare mutation. And it led to, a unique treatment, lead article in the New England Journal, and the NIH started an exceptional responders program, and I've been a fan of his ever since. Dr. Lorch.
Well, thank you. Thank you for that kind introduction. I was always wondering, is she really talking about me? But anyway, is it okay? Oh yeah, yeah. Actually, I don't. Exactly. Good. Yeah, no, I also have to say that the ThyCa meeting is always a highlight of the year for me because we spend so much time talking amongst ourselves and with providers, but then to speak in front of a group or to have this group of actual survivors or people who've been touched by this disease in front of you, that's something different altogether. So thank you very much for giving me the opportunity to speak to you today. And so I'm not at all unhappy about the fact that we didn't, that I don't have my slides up, because I personally always find these slides more distracting than actually helpful. And what I would propose, unless you have some other suggestions, is that we just talk a little bit about immunotherapy and immunotherapy in general, immunotherapy and thyroid cancer, not just follicular thyroid cancer, because I think that would probably be a little bit narrow. And then also about some of the newer developments that are happening at Northwestern, but also elsewhere. So immunotherapy really has turned the field of oncology upside down. And what's exciting about immunotherapy is not so much that there are a lot of people who respond to it. Sometimes they do, like in diseases such as melanoma or Merkel cell cancer. You have like 70% response rates, similar to what you find with lenvatinib in thyroid cancer. You don't see that in cancer and other cancers either. But what's exciting about them, about immunotherapy in any malignancy, is that you have these long-term survivors. So people are treated for 2 years, cancer goes away. Every time you get a scan, stop, and the cancer never comes back. Now, obviously, that's like every oncologist's and every patient's dream. Now, unfortunately, it turns out that thyroid cancer, those response rates are pretty. For example, papillary thyroid, the response rate, the typical called, I'm sure you're familiar with news and ads and such. The response rate there is actually less than, and then you consider that there is really potential, at least, toxicity that's really different from what we would expect, for example, from with lenvatinib or with traditional chemotherapy, it's, where you have nausea and vomiting, and you have with lenvatinib, you have weight loss and fatigue and all these other things. Immunotherapy is totally different. The side effects of immunotherapy are basically the result of getting the immune system really, really angry and starting to attack all kinds of things that it shouldn't be attacking. And most commonly, that affects the colon, which then causes colitis, and which then causes lots of diarrhea. Meaning, like, if, often it's like cholera style, liquid bowel movements, 15 per day. So this can be very severe. And then also things like hepatitis, but it can autoimmune hepatitis without the virus. But it can affect any organ in your body. And personally, I find it surprising that this is actually relatively infrequent. So these severe side effects of immunotherapy you get in about 15% or so of all cases. The rest has either no symptoms at all. Everybody gets a little bit of fatigue, but it's nothing compared to what you see with lenvatinib or many of the other TKIs. But many people are also just fine. So it's a totally new treatment paradigm that came about 10 years ago. And there are currently 2 drugs that are FDA approved that you can also use for immunotherapy in thyroid cancer. One of them is Keytruda. The other is, or 2 groups. One are the PD-1 or PD-L1 inhibitors, immune checkpoint inhibitors. Keytruda most commonly, but also things like Opdivo, nivolumab, avelumab, atezolizumab. These are all variations on the same theme. They all have their FDA approved indications, which means that they're out there and you can get them. And then there's another group of drugs that target something that's called CTLA-4. And CTLA-4 is basically an enhancer of lymphocyte function. And actually, among these 2 drugs is clearly the one that's associated with more side effects. Anyway, so these drugs came about roughly 10 years ago. And initially, of course, and this is just, the way drug companies think, initially, the most popular or the diseases that they went after were breast cancer and colon cancer and lung cancer, like things that where you have a lot of patients. And then around 2015 or so, there was sort of that first trial where there was a trial with Keytruda in many of these diseases. So basically, like Merck just put them all together in one trial, all that stuff that they didn't really want to bother with, like individually, they just put it all together. And in this cohort, there were 21 patients with thyroid cancer, with iodine refractory, differentiated, not anaplastic, but differentiated thyroid cancer, papillary, follicular, differentiated. And among those, there were exactly 2 responders, and that's where this 9% number comes from. So 2 out of 21 patients actually had a response. And these responses were also not very long-lived. So there was basically a bit of disappointment after that. And the thought was, well, maybe it's a rare disease. So for interest from drug companies is kind of low to begin with. And it doesn't seem to work very well. But then the question is, why did it not work better? And the obvious explanation is that if you do sequencing on thyroid cancer, what you usually find is not very much. These are tumors that have very, very few mutations. Now, if you go to the less well-differentiated thyroid cancer, things like poorly differentiated thyroid cancer, and then go all the way to anaplastic thyroid cancer. Anaplastic, by the way, means unformed, Greek for unformed, which means like totally de-differentiated thyroid cancer. There's then an increasing number of mutations. And the reason why that's important is that these mutations are thought of as the connecting points where the immune system basically latches onto the tumors and starts to recognize them, and then eventually activates the system and immune cells come in and destroy the tumor. So for at least for differentiated thyroid cancer, there isn't a lot for these cells for the immune cells or for the immune system to latch onto and to recognize. And that's a problem. So as Robert said, I spent a few years at Dana-Farber, and there was a very active collaborator. His name was David Barbie. He's still there. He's a thoracic oncologist, and he had developed a model system where you could basically take a patient's tumor, stick it in a little device, with a little collagen cylinder, and these cells actually survived there and grew for a while. But what was more important was that the immune cells that were also contained within this biopsy or within this tissue sample, the immune cells survived as well, so which made it possible to then test immunotherapy drugs in your model system and directly on patient material. And we did that, in a handful of cases. Those were all poorly differentiated and anaplastic, and the reason was we wanted to give the immune system something to recognize. And then, so these cells were growing very happily with what's then referred to as their tumor microenvironment, which means tumor cells that are part of the tumor stroma, things like fibroblasts, so basically things that actually, that make up the structure of a thyroid cancer, but then also the immune cells. And what we saw was when we tested PD-1, Keytruda, versus some of these other drugs like the CTLA-4 type drugs, things like ipilimumab, we found that ipilimumab was actually conveying a lot more cell-killing potency in this model system compared to just PD-1 alone. So that was a basis of a trial that we ran there. That was an investigator-initiated trial. It's now accepted in a very nice journal. It's coming out probably in the next 5-6 weeks. But what we basically did was we took about 30 patients with differentiated thyroid, iodine-refractory thyroid cancer. These were papillary, follicular, and also quite a few Hürthle cell, or oncocytic, as they're called now, oncocytic thyroid cancer cases. An exploratory cohort of 10 patients with anaplastic thyroid cancer and 5 people with medullary thyroid cancer. And what we saw was that, again, to our disappointment, the response rate in this group, the main group, which were the differentiated thyroid cancers, there again, the response rate was only 9% across the board. But there was clearly a pattern. So there was one of those cases that did respond. It responded very profoundly, was poorly differentiated, as we would have predicted. And then there was this other group, which were Hürthle cell cancers or oncocytic thyroid cancers. And among 7 people who we had, we also saw 2 very profound responses. Again, lenvatinib can do that too. Lenvatinib can very reliably shrink not anaplastic, but Hürthle cell thyroid cancers. But what's exciting about that is that these responses were very profound, and we could eventually stop treating these people with these 2 responders with oncocytic thyroid cancer. And the cancer, they did eventually recur, but it took several years. So that was clearly a success. Now, anybody here with Hürthle cell or with an interest in Hürthle cell? Okay. Yeah. Good. That's a good sign. So Hürthle cell is a little bit of an odd one. Again, compared to other differentiated thyroid cancers, there are even fewer mutations. But what they have are 2 things. First, there are some recurring mutations in the mitochondria of those cells. And then there are, what's also unique about oncocytic thyroid cancer is that they have this, what's called near complete haploidization of the chromosomes. So you probably know we all have like 2 sets of chromosomes. They're basically like one set is from your father, one is from your mother, and then they get sort of mixed together a little bit, and that's why we're not coming out as direct copies of either one. But they're basically deposited in two sets of chromosomes, which are identical in terms of appearance, in terms of the genes that they stand for, but one is from your father, one is from your mother for each gene. It can change again, but it, each chromosome is different. So if cancer cells lack one set of copies, and that's basically, and all oncocytic thyroid cancers have that, then one set is missing, which means like one set of genes is missing, which means that if something goes wrong in that remaining set of chromosomes, there's not the same gene on the other chromosome where you could then switch over to. So that makes these cancer cells just very susceptible to mutations in general, but especially mutations in what's called tumor suppressor genes. So genes that are there to then recognize and destroy or repair cells that are about to become cancerous. Having just one set of chromosomes, I'm sure, is a very strong signal to the immune system, and that's why we saw a number of responses. We actually did a follow-up study that we started at Northwestern, and the drug company sort of lost interest in this drug because really for business reasons, but it was actually very successful. This was then designed based on that last study that was that was essentially a drug, what's called a bispecific monoclonal antibody. So it's PD-1 and a CTLA-4 antibody basically fused into one. And it actually worked in one case with no real big response, but with disease stability for some time in a patient with thyroid cancer, with Hürthle cell thyroid cancer. But then also among 4 people with anaplasty, we actually had 2 profound responders. So I'm a little bummed that they pulled the plug on this drug, which again, that could have offered them a chance to, for FDA approval and so on, but it's a small company and they just ran out of cash. So anyway, that's PD-1 and CTLA-4. So it does not work so great for the overall differentiated thyroid cancer group, with the notable exception of Hürthle cell or oncocytic thyroid cancer, and it works great in anaplastic thyroid cancer. So now, what are the next steps? Right now, there aren't too many. There are some data, actually from Germany, my home country, where they combined. There was one group in a town called Freiburg, where they combined pembrolizumab, again Keytruda, with lenvatinib, and saw a very high number of responses, something like 60+% in anaplastic and poorly differentiated thyroid cancer. There were a couple of mythological issues with that study, and the first one was a retrospective study, so then they studied that prospectively, and in anaplastic at least, the response rate seems to be somewhere in the order between 40 and 50%, and which is encouraging for anaplastic thyroid cancer, but to my knowledge, there's nobody studying that in differentiated thyroid cancer, papillary or follicular. Now it's become a very popular regimen in anaplastic thyroid cancer. Now, what are the other developments? And unfortunately, there aren't a whole lot right now, at least as far as immunotherapy is concerned. But there are many drugs out there that obviously have a track record. Lenvatinib is one, sorafenib is another, and those happen to be FDA approved, but there are also many others, things like pazopanib and variations on this lenvatinib theme. There are many of those. The fact that there seemed to be some what's called synergy between Keytruda and lenvatinib, that was that study from Germany that I just mentioned, because this was clearly, there seems to be clearly more activity when these drugs are combined than with either drug alone. So this is not just a summation of effects. Lenvatinib also has virtually no activity in anaplastic thyroid cancer. Um, so that there seems to be a synergistic effect. So they basically potentiate each other's effect in anaplastic thyroid cancer, at least. And that led people also to look into other drugs that have been around. There's, for example, a drug called everolimus, which is an mTOR inhibitor, which also actually happens to work really, really well in Hürthle cell cancer. And I only recall, I think, one case that did not respond to everolimus. It's totally different from the tyrosine kinase inhibitors. It's also a pill. You take it once a day. It has a totally different side effect profile. It suppresses your immune system. It does a number of other things, but it's an alternative. It's also NCCN or guideline recommended. So it's not there's no big phase 3 trial, but it's clear that it has some activity. And when we and others looked into why this drug actually works, it turns out that it also influences the immune system in a way that makes the drug more that makes the checkpoint inhibitors, again pembrolizumab, but also perhaps CTLA-4, more effective. Now, there are currently no trials to look into this further, but I think that might change over time. There is one. There are actually two trials that we've recently we initiated and recently got funding for, and where we will look into this very systematically. One is for iodine refractory thyroid cancer. So differentiated thyroid cancer, where we'll be studying a drug that's called XL092, which is a drug that is very similar to cabozantinib, but it's a third generation tyrosine kinase inhibitor. So it's basically a drug that's been developed to make cabozantinib less toxic. And anyone who's been on a tyrosine kinase inhibitor knows how important that is. But what we will specifically look for is what the changes are to the immune system while people are on these drugs. And is there potentially then a reason to combine this with Keytruda or one of the CTLA-4 inhibitors that I mentioned before? So this is a trial that'll be coming online sometime probably later this year or early next year. And then there's another a trial that we also we're moving forward with that's with a drug that's called enfortumab. Now, I don't think anybody here has probably heard of it. I had barely heard of it because it's not a drug that's used at all in head and neck cancer, thyroid or squamous head and neck cancer, which is basically what I do. But it got FDA approval in bladder cancer. Now, strangely, drugs that work in GU oncology often also work in thyroid oncology, which is weird, I mean, why would that be? I mean, it's not even the same region of the body, right? So opposite ends, really. But for some reason, that seems to work. That's also true for kidney cancer, I mean, all the lenvatinibs and other nibs, they work pretty well for kidney cancer too in our standard of care there, in addition to a bunch of other things. So anyway, so this drug called enfortumab is something that's called an antibody-drug conjugate. Antibody-drug conjugates are all the rage right now in oncology, and for a reason. But essentially, what they are is an antibody, a monoclonal antibody, so an antibody that attaches to things, and that is then coupled with a payload, and that's typically a chemotherapy drug. And the idea is that these antibodies, so you basically pick an antibody that attaches to a cancer cells, and it's not just in thyroid, in any cancer really, something that attaches to the cancer cells, and preferably, very specifically, without much binding to much else. And we know that once they've attached, they get actually resorbed. They get taken into the cells, and the cells start to digest them. And then that's what releases the payload. And then, then the tumor gets hurt. And we know, and we're going to get more data on that, but we know that this structure that this antibody is directed at. It's called Nectin-4, which is a cell adhesion molecule. It is actually expressed in thyroid cancer, and in more aggressive thyroid cancers, it's expressed more than in more benign thyroid cancers, which is exactly what we want. So this is a trial that'll become available sometime second half of next year, probably. But what's interesting about that, and why it's relevant to the theme here of immunotherapy in bladder cancer, it's actually there's clearly synergy between Keytruda and this drug. So once we've demonstrated that this drug has some activity in thyroid cancer, I think we want to see that. But once we've established that part, I think it's going to be easy to then just add something like Keytruda and try to enhance the immune effects. And with this trial comes a lot of translational research where we're trying to understand what happens to the immune system in people and in people's tumors when this drug is given. I think with that, I wanted to maybe switch to questions and answers if you like. Okay.
Hi. Do you have
Hello.
questions? Hello. My name's Angelica Kapoor Davis. I'm your virtual host here.
Great. Nice to meet you.
Nice to meet you. We do have a question in from the online folks. They wanted you to repeat what you said about what worked well for ATC, and they're asking if you said that Lenvima didn't work well for it.
Yeah. So when Lenvima was developed and it became clear that it was a useful drug in thyroid cancer, then there was an abstract that was presented probably about 7 or 8 years ago. The abstract was from Japan, and they said that they had treated about 10, relatively small group, 10 anaplastic thyroid cancer patients, had seen responses in about 4 or 5. And that was obvious, and that was at the time when we had just figured out that lenvatinib was actually, or that thyroid cancer was actually treatable. So that created quite a stir. But then then there was a phase 2 study, which was a multi-institutional international phase 2 study, and with about 32 patients or so, also with anaplastic thyroid cancer, and there was only 1 patient who responded, and that pretty much put the nail in the coffin of that. But then again, that's why it was so surprising that when the data emerged that Keytruda plus lenvatinib was so effective in anaplastic thyroid cancer, why would that be? And the explanation is, well, there must be some kind of a synergy. So it must unlock, lenvatinib must unlock some potential of in pembrolizumab to make it work a lot better, because both worked much better than each of them alone in anaplastic thyroid cancer.
That's fascinating. So you were talking about there weren't any more online, so I'm asking my questions now. Is it the PD-1 CTLA-4? So you were saying it was Herthel cell and anaplastic that had good responses, but pharma chose not to pursue it because they didn't have funding.
Yeah. Yeah. That's another, it was one of these bispecific monoclonal antibodies, and that the idea here was to have an antibody that binds to 2 different structures instead of the same structure in both of its little arms. So monoclonal antibodies look like little Y molecules, and the tips of the Ys, that's the area that binds to stuff, and it binds very specifically. So a number of years ago, there was this technology developed to create monoclonal antibodies that would bind with one arm to one thing and with the other arm to something else. And the reason why that was done was the hope or the thought, and also some data that suggests that that you would then choose one epitope, so one binding structure, say on a cancer cell, and the other on an immune cell, so that the antibody would essentially glue these two things together, because we know that ultimately you need the direct contact of immune cells with the cancer cell in order to recognize what's going on. So that was the idea, and that's why there was a bit of hope that this would work better than, again, either drug alone. There has been at least sort of like this idea that you could then in real people bring cancer cells and immune cells sort of mechanically together. It's not clear whether that really pans out. So there has been a little bit, I wouldn't say disappointment. There definitely, there are several that are getting FDA approval, and there's at least one that has FDA approval already. So there's definitely something there. But you know how Wall Street and everybody else is, it's like, it's always the newest and shiniest thing that they go after, and in that case, that was a victim of that. But I mean, they haven't completely closed the door. They might actually reopen it and continue. But again, it's all about funding, and I mean, we're in a way. I mean, nobody's getting rich by doing clinical research. I mean, it barely covers the cost. I mean, what drug companies, especially for investigator-initiated trials, which are trials that you bring to a drug company and ask them for drug and/or funding. These are usually done by academic centers because there's some
Okay.
investigator, people like me who's just interested in that, and there's usually not a huge budget attached to that, so nobody gets rich from that. But we still do need to cover the cost of running a trial, which is also very expensive. But yeah, so we'll see. Maybe this trial will come back from the dead, but maybe not.
So the XL, you said XL
092, yeah.
092? Okay, so that is the
No,
N-fortunab,
so
or that's working with.
right. So this is a tyrosine kinase inhibitor. So this is a drug
Okay.
which is generally very similar to lenvatinib and especially to cabozantinib. It's also made
Okay.
by, or it's been developed by Exelixis. They've tweaked a few things, and the idea is to keep it as effective as cabozantinib and lenvatinib, but to make it less toxic. So this is basically like a straightforward, what's called a phase 2 trial, which means everybody gets the drug. We know the effective dose for this, so it's not a phase 1 where you're just starting really low and then going higher. It's like everybody knows what the dose is, everything. But where the immunotherapy connection comes in is that we'll be specifically looking for changes in the immune system among people who start treatment on this drug. But
Okay.
this is itself not it's not developed as an immunotherapy drug.
Right.
It's a research project. Yes.
Do you consider the CAR T to be immunotherapy?
AI
Can you
resistance, for
Oh yeah,
instance.
right. I totally forgot about that. Yes. Yeah, no, that's good. Yes, CAR T. So as you know, there are 2 trials right now going on with CAR T cells in thyroid cancer. One is a medullary thyroid cancer trial at the University of Pennsylvania. And the other one is an immunotherapy, a CAR T trial that's happening at MD Anderson, at Northwestern, and at City of Hope in California. And currently these are the only ones. Now they're still in their phase 1 portion of the trial, which means that you systematically increase the dose, and you're primarily looking for toxicity. Now, obviously, you're also looking for effectiveness, but that's not really the main purpose of a phase 1. So right now, it's just increasing the number of cells that are reinfused. I'm also not sure, is everybody familiar with what CAR T cells are? So it's basically like taking your own lymphocytes and then changing them, manipulating them in the lab so that they recognize a certain structure on a cancer cell. Like in the case of the medullary thyroid cancer, for example, it's a structure that's a little bit related to CEA, which is a tumor marker. And in the case of the other CAR T trial, that's primarily for anaplastic thyroid cancer, but also poorly differentiated thyroid cancer. There, the epitope that the CAR T cells are programmed to recognize is called ICAM1, and which is a cell adhesion molecule, which is predominantly expressed around cancer cells. So, there was an abstract of the CAR T trial for poorly differentiated and anaplastic, like the one that we here and we and at City of Hope have open. There was an abstract presented this year, and it's pretty well tolerated. There's definitely some activity there. There was a patient with anaplastic thyroid cancer who actually also had a fairly sustained and ongoing response. That was among about 10 patients or so that have been treated so far. So CAR T cells are immune, they rely on the immune system. It's not just that somehow these CAR T cells then start attacking the cancer cells or somehow destroying them. They still rely on the immune system. It's also that they, once they're reinfused, these are living cells. They're also expected to then grow and proliferate and become more numerous, and basically create an immune environment that allows the patient's own immune system to destroy the cancer cells.
You know how long it will be before it goes to phase 2?
Yeah, so pretty soon, probably early next year is the projection. Yeah, so they're also looking into expanding the capacity. Right now, that was a bit of a limiting factor here, that it was the CAR T cells were made in a primarily academic lab, but it's going to be a more commercial lab now where they're produced. So there should be a lot more capacity.
Are there any hi, thank you for coming and talking to us.
Oh, of course.
Are there any noticeable differences with CAR T with PDT versus poorly differentiated versus anaplastic? Is there any initial findings between it saying anything?
Yeah, I mean, what was striking was that basically the most promising responses so far were all in anaplastic and not in poorly differentiated thyroid cancer. So the question will be whether to continue with or focus on anaplastic versus continue with more broadly. But these are decisions it's basically primarily the drug company that's making that. The company's name is Affimmune. Yep.
Yeah, I had been on Lenvima for 6 years and it stopped working. So now, of course, I'm on the Cabo. Is there work with the immune system and that also? Or would I have to go back to the Lenvima for the combination?
And what is the histology? Is it papillary or follicular?
Papillary and follicular.
Uh-huh. Okay. Yeah, so I mean, the fact that Lenvima worked for 6 years is pretty good, because from that you can sort of extrapolate to some of the other nibs, like sorafenib and pazopanib, and there's between 5 and 10 others. And it's quite likely, it depends a little bit on why this stopped working. There's a variety of reasons why that could be the case. But having been on it for such a long time makes it much more likely for you to continue to have a response to some of the others. Now, immunotherapy would probably not be just based on the low response rate, or CAR T would not be something that you would reach for, right away. But it's entirely possible that in the response that you've had now for 6 years, that your own immune system actually played a role in that. Just like for anaplastic thyroid cancer, where lenvatinib plus pembrolizumab was so much better than pembrolizumab alone, and definitely a lot better than lenvatinib alone. So, I mean, the effects on the immune system are probably the same. It's just that for differentiated thyroid cancer, the immune system has a much harder time recognizing that there's something wrong, and that therefore, the effects are just much smaller or more subtle. But it doesn't mean that it doesn't play a role. It may have, and it may in the future.
I had a question regarding the CAR T. You're directing it against one antigen, like the medullary was GFR alpha 4.
Mm-hmm.
So if that's your target, is there in the future, can you envision just generating cells that you can give to any patient with that target, or is the immune system just going to pick those off right away?
Right. So that's a good point. So the epitope, like the surface structure that you program the CAR T cells to go after, does not necessarily have to be particularly vital to the cancer cells. It just has to be there. Now, it helps if this is also vital, because resistance to CAR T treatment, of course, could be that the tumor cells just stop expressing whatever the CAR T cells are directed at. And if the cancer cells then still can survive and thrive, then you've probably you've lost your efficacy. And it's a little bit surprising that that doesn't happen more often, because like, for example, like this for the medullary thyroid cancer case, but also for ICAM-1 for the anaplastic and protodifferentiated CAR T study. These don't seem to be absolutely crucial molecules for those cancer cells. But theoretically, it shouldn't play a role. And then once there's an immune reaction that's sustained, the thought is that there are more immune cells and more T cells coming in, not CAR T cells, but regular T cells coming in, and recognize now, because everything, you've basically turned this environment, this tumor microenvironment, in something that's then called hot. So there's a lot of immunologic reaction going on, that this at some point then becomes self-sustaining and becomes independent of the original epitope that it was directed against. And that's in a sense, that's also very similar to the antibody drug conjugates, where, like, for example, Nectin-4 with enfortumab, cells are probably just fine, without Nectin-4, but it works beautifully in bladder cancer and hopefully also in thyroid cancer. It's not so easy for these cells to just turn off expressing the epitope, and then they're fine.
All right, Dr. Lorch, thanks
Good.
for
Well,
a
thank
very
you.
nice discussion. Thank you.
Thank you.